Good morning, everybody. I'm MacGuineas. I'm the president of the Nonpartisan Committee for a Responsible Federal Budget. So glad you're all able to join us today for what I am certain is going to be a really fascinating and important policy discussion. I'm particularly pleased to be here today because we are launching an exciting new initiative, the Health Savers Initiative, with our partners, West Health and Arnold Ventures, where we are going to be focusing on developing a whole slate of new policy initiatives to focus on cost controls, savings. This is a crowd where I don't have to go through and explain that healthcare costs are both too high and growing at a rate that is non-sustainable. We will have to make changes. And the important thing is that so much of the discussion in the past has focused less on how to do that right in the right way, more on how to obfuscate the costs, shift the costs. We are going to have a program that is going to focus completely on how you bring costs down for consumers, for families, for businesses, for governments, for purchasers of healthcare, to the greatest extent without affecting the outcomes of healthcare savings. We believe there's a tremendous amount of innovative new work that can occur here. Another reason I'm really excited to be launching into the healthcare space, other than the fact that it's clearly so important, is one of the things that most affects American families. It's also one of the things that most affects the federal budget. But it's also, importantly right now, one of the few areas in public policy where we are really seeing movement and openings for real progress and hope, where we have members of Congress, both parties, both chambers, working on important legislation. At a time where it seems really dysfunctional, where it's very difficult to pull things out of kind of the policy camps and get work done, I think the recent months have been so encouraging, what we've seen out of the healthcare space. So we're very excited to be working on that with partners on Capitol Hill. To that front, I am thrilled and really pleased to see, look at this bipartisan duo. You don't see that enough. But I'm really pleased that we are kicking off this conference this morning with Chairman Grassley and Senator Wyden, who have been doing incredible work in building legislation out on controlling drug costs, and importantly, in a bipartisan way. And I just have to stress that because there are so many policy solutions, but to be able to meld what will work from a policy perspective and also is doable in a political arena is incredibly important, so we can get things done and they can stick. We don't want them pendulum back and forth. We actually want policies that will be durable. So to both of you, I can't thank you enough for the incredible work that you have been doing on healthcare. At the Committee for a Responsible Federal Budget, we are very eager to reinforce, help work with you all in any ways that are possible. And specifically, thank you for joining us this morning. Senator Grassley, you're going to give remarks first. Thank you.
Thank you. Thank you, President MacGuineas. You've given a good introduction and opened up a conversation that Senator Wyden and I have had since last November. Good morning to all of you for being here for such a very important subject, and a very special thank you to the two groups participating, the Committee for a Responsible Federal Budget, for all the work that you do to encourage lawmakers to take fiscally responsible approach to governing, and also to the West Health Policy Center for all that you do to foster public debate on ways to save taxpayers and patient dollars by making our healthcare system more efficient. The launch of the Health Savers Initiative couldn't come at a better time, and the cooperation that West and the Federal Committee for a Responsible Federal Budget is a perfect example of your cooperation on the outside, and you see up here that we wouldn't even be here with the cooperation that Senator Wyden and I have, and it's been a pleasure to work with him on this subject and other subjects as well. Have you ever heard anybody say that healthcare costs were too low? Of course you haven't. And in fact, high healthcare costs consistently rank as one of the top concerns that I was raised to me as I hold my annual 99 county meetings and Q&As with my constituents. Between the skyrocketing prices of prescription drugs, surprise medical bills, and ever-increasing premiums and co-pays. Healthcare is breaking the bank for millions of Americans every year. And let me give you some backup facts on that. A recent poll by Gallup, conducted by the partnership with West Health, found that 1 in 5 American adults said that they couldn't afford the medicines that they needed. And 34 million Americans said that they knew someone who died because they couldn't pay for the treatments they needed to survive. As the richest country in the world, where the most miracle and life-saving drugs are created, we ought to consider that a real shame. It's important that we consider that something that we simply have to address if we want to continue to be the country that not only invents cures, but at the same time delivers cures to Americans in need. Now I'm saying what you already know here, and balancing the federal budget is no easy task. Putting both parties' spending wish lists on the national credit card seems to be the only way that we ever are able to keep the government operating and passing our appropriation bills. That poor habit is setting up our country for big fiscal problems down the road. And Senator Wyden and I are trying to deal with a part of that problem by dealing with prescription drug prices. So that's why today I want to visit with you about some of the biggest ways we can save taxpayer dollars and put programs that we all care about, like Medicare and Medicaid, on a stronger financial footing. Earlier this year, the Senate Finance Committee passed a bipartisan Prescription Drug Pricing Reduction Act by 19-9 vote. The legislation includes the most significant reforms in Medicare in nearly a generation. And that was the last time that I led the Finance Committee, and that was under President Bush, when our committee authored the legislation that created Part D of Medicare. Part D's free market structure has worked well. It's one of the only program that I know of that has continually come in under budget. While I'm committed to maintaining Medicare Part D free market structure, what cannot continue are the staggering year after year increases that far outpace inflation. Not only is the status quo unsustainable, and that's from a budget perspective, but it's not fair to ask the taxpayers and patients to continue to put bills, no questions asked. So we're asking a lot of questions. I'm not one to vilify private individuals or business seeking or making a profit. After all, our system of economics is the foundation of our great wealth that we have in this country. Not only that, but what we call capitalism has lifted billions out of poverty worldwide since World War II. As you know, the statistics since World War II, at that time, 50% of the world was in poverty. The most recent statistics have 8%. And the free market incentive structures created a system that led to the development of new treatments that save and extend countless lives every day. But we also must recognize that when it comes to federal health care programs like Medicare, where the government has already inserted itself very heavily into the marketplace, we have a duty as legislators to protect the taxpayers as well as delivering health care. That's why pharmaceutical companies will be able to recover their research and development costs for the past future drugs when they launch a new medicine. And they're going to be able to make a profit on top of that. But But what they won't be able to do under Grassley Wyden is to continue hiking prices past the rate of inflation every year. This unjustifiable practice must end if there's going to be any sanity in our prescription drug market, or if there's going to be any fairness to the taxpayer. Reforming the federal entitlement program is often referred to as the third rail of American politics for the electoral consequences that seem to befall anybody who dares touch it. But obviously, Senator Wyden and I aren't scared of that. Reforming the federal entitlement program is something we must do. But we flip the conventional wisdom on its head by not only saving taxpayers a little over $100 billion in this legislation, but we're also increasing benefits to our beneficiaries. Our bill would lower beneficiary premiums by $6 billion, reduce their out-of-pocket costs by $25 billion, and even lower drug prices in the commercial market. And that's not this senator saying that. That's according to the independent Congressional Budget Office. And if you want to know where they have any sway in this town, they're like God in this town. If they say something costs something, that's what it costs. And if you don't believe it, you better have 60 votes to override it. The Grassley Wyden bill is the only comprehensive bipartisan prescription drug legislation currently being debated in the Congress. And I want to emphasize that. The only bipartisan one. There's a lot of Republican suggestions, there's a lot of Republican opposition to our bill, and there are Democrat proposals, but there's nothing that can get 60 votes in the United States Senate, and this bill may not have 60 votes today, but when Republicans wake up to the fact that 22 of them are for election, and in every state, it's an issue in their state as it is in my state, and I'm not up for election, they're going to soon realize that this is the road to doing something responsible for the taxpayers and also exercising good judgment for the health care of Americans. But we're not there yet. Right now, Ranking Member Wyden and I are working further to improve our legislation by delivering more savings to the beneficiaries. This updated version of the Prescription Drug Pricing Reduction Act will improve the out-of-pocket cap by giving seniors and Americans with disabilities more flexibility when it comes to upfront costs. It will also include improved mechanisms to reduce the consumer pay out-of-pocket when they go to the pharmacy. In the coming weeks, we'll be releasing this amended legislation. Just had word with Senator Wyden that we're making good bipartisan progress in that effort. We hope these changes will help the bill garner the support we need to turn it into law this year, meaning yet in 2019. And it will be important for Congress to continue working to lower health care costs in other areas as well. And with that, I'd like to say that I'm very glad that my friend Senator Wyden is also here to discuss it from his point of view, our bipartisan bill. I often say that in the United States Senate, nothing gets done unless it's bipartisan. And so at the beginning of this year, Senator Wyden and I sat down together and agreed to take a bipartisan approach to lowering the price of prescription drugs. So I thank you, Senator Wyden, for your hard work and his understanding approach when crafting the bill with me, because his dedication to compromise and, more importantly, good faith negotiation, lower prescription drug prices are in sight for tens of millions of Americans. Now it's up to our colleagues in Congress to join us in this effort and finally deliver what our constituents have been demanding. And you folks, including every one of you in this room, unless you represent the pharmaceutical companies, you're a part of that process. And you could be a part of it as if you were pharmaceutical companies as well. So I'm hopeful that we can achieve, working with you and a lot of others, a more affordable health care for taxpayers and patients very soon.
Thank you.
Mr. Chairman, thank you very much for exceptionally gracious comments and this partnership that we have built. I can tell y'all that if people have heard that Chairman Grassley and I were committed to coming up with a bipartisan bill in this political climate to lower prescription drug costs, I think they would have, when we started, said there's about as much chance of that as Ron Wyden getting his childhood dream of playing in the NBA. I think they would have just said, impossible. Look at the divisions between Republicans and Democrats. And as the chairman correctly noted, not only is this the only bipartisan plan on offer, Mr. Chairman, I've been kind of trying to scour the history books, and I can't find another. And Maya, thank you for your good work, and you're a guru and all this. Maybe you know of an example. I can't find another example in a generation on an issue of this magnitude, where there are billions of dollars at stake. We're talking about the country's flagship health program, Medicare, Medicaid as well. And what the chairman did, and he laid out the things that we were talking about working on in the future to make this even more attractive as a package to both parties, to Republicans and Democrats, is we recognized what bipartisanship is about. You know, bipartisanship is not about putting on a dark suit and then a pretty tie or a top or something and going out and going, I'm bipartisan. It's not about taking each other's bad ideas and acting like you're doing something important. It's about taking good ideas. And that's what the chairman and I have sought to do. I mean, Medicare is a guarantee. It's not about, it's not a slip of paper. It's a guarantee. And the chairman respects that. And both of us said that if you're going to protect the guarantee in a climate like this where 10,000 people turn 65 every day for years to come, you're going to have to do more to make the system more efficient. Lord knows there's a lot of money on the table that you can make more efficient. We're going to spend $3.5 trillion this year on health care. There are about 330 million of us. You guys can do some quick math out there. Divide the 330 million into 3.5 trillion, and you can send every family of four in America a check for $40,000. Say, here, go buy your health care. Now, don't walk out of here and say Ron Wyden's advocating that. It's the biggest redistribution of wealth in America and all that. But I'm saying the opportunity that the chairman described for us to actually make some savings is extraordinary, and you just need some bipartisan goodwill. And it was not easy. We went at it literally month after month, day after day. Our staffs did wonderful work. And let me talk to you just briefly about some of the challenges. One of the issues dealt with the fact that pharma always says anything that in any way changes their business model. And boy, what a gravy boat they have. You know, insulin has been the poster child for all this. And the chairman and I are still working on, our staffs even this morning are working on trying to make the bill even stronger in this area. Insulin prices have gone up 13-fold in recent years. Insulin is not 13 times better. It is basically the same insulin that's been around for decades and decades. The prices go up because that's what's allowed under the system. And the chairman and I are focused on changing that. And what we said is, hey look, we're not going to get in the business of setting prices. Chairman and I are not going to sit in our offices and say you can charge $7.12 and all this kind of thing. Companies will make those decisions, private decisions. But if people are out there price gouging and charging way over inflation, we're going to cut their subsidies. And what are we going to do with the subsidies? We're going to use that to help the vulnerable poor people who can't afford their health care, so that you're making better use of that $3.5 trillion. That's an example of how we broke new ground. And by the way, you'll hear me talk a lot about that in the days ahead. I don't think there's a constitutional right in healthcare for powerful players in healthcare to get unlimited subsidies from the federal government. And we're going to be talking about those ideas in the future, number one. Number two, the chairman and I said, there's really something out of whack with these middlemen. Have you all heard about the PBMs, pharmaceutical benefit managers? So I was director of the Great Panthers years ago, the senior citizens group, and I had a full head of hair and rugged good looks and all that. And PBMs came in about, 40, 50 years ago. And they really made a contribution because people didn't have the data and they didn't have the expertise. So they came along and said, hey, for the Iowa government, our PBM will negotiate a good price for people in the Iowa government, or a business group in Oregon or something. But now, I don't think those middlemen give us the same value. I don't know what they put in their pocket, what they put in your pocket. So the chairman and I have said, we're going to have some real hot lights of accountability. We're going to have what's called the see-through act. And we're also going to have something that looks at excessive price hikes. We're going to have to justify them, something we used to call the spike act. So I think the fact that the chairman was willing to say that we were going to go after the middlemen, I think was another important contribution to the debate. I'm appreciative of that. And then finally, our catastrophic cap talked about sensible health policy. What we're basically saying is, let's give the chairman another round of applause for his argument. He's got our catastrophic cap was so important in the area of Medicare because it just basically brought Medicare in line with everything else. People would say, the seniors have to worry about like losing their home or their future or anything because drugs are so expensive. Why shouldn't they get the same kind of catastrophic protection, the kind of security that other people get? So that was what the catastrophic cap was all about. And now, as the chairman touched on, we're working on improvements in order to kind of try to make sure that the senior doesn't have to pay the money up front, but you in effect spread the costs in a way that's more favorable to the consumer. But again, you've still got costs on your mind. So I think that gives you a little bit of an overview. But I want to just before we close, and I don't know what you want to do, Maya, if you want to have a couple questions or anything else, is we also think, and this is part of the national debate, that healthcare is very much driven by empowering communities and people at the local level. And so the chairman and I have also been interested in helping the local pharmacist and the consumer at the counter as well. And this goes not just to PBMs, but some other possibilities as well. And it also reflects our judgment that the kind of healthcare system that works in rural Oregon might not necessarily be the best fit for Detroit. And so what you want to do is come up with a way to ensure flexibility at the local level. So if you're looking for something that is bipartisan, something that goes right to the heart of some of the principles we ought to be looking at for holding down healthcare costs in the future. If you share my view that shouldn't be big price control regimes, but these powerful players are not entitled to unlimited subsidies, and you think that there are a lot of people who've found their way into the supply system, so to speak, in healthcare, like the PBMs, and there really needs to be more transparency and accountability. We hope you'll go out of here, talk to Democrats, talk to Republicans, find people on both sides of the aisle, because we think that what Maya and y'all are starting today with the health savers and the like is absolutely key. If you look back even at the Affordable Care Act, and many of you know I had a bipartisan bill there with 6 Democratic senators, 6 Republican senators, I think that even the strongest supporters of the Affordable Care Act will agree that more has to be done on the cost side, because if you expand access without really looking at costs, you're going to have a whole cascade of challenges, including finding providers, and that can end up being pricier than it ought to be. And what you're doing with your program today is you're putting costs up there as central to everything else that gets debated. In that sense, this program is long overdue, and we look forward to working closely with all of you in the days ahead. Thanks for having me. Softball's welcome at this hour. Yep. Well, what there is in there, and I don't want to front run where we are, what I think we've done is we've really exposed with the See-Through Act and the provisions a lot of the way in which this system has really been punitive for people who are part of your group, the local pharmacists and others. I went to 7 pharmacies, small pharmacies in rural Oregon, that gave me chapter and verse about how the PBMs, the big PBMs, end up really milking them, pretty much, nonstop. So I will tell you, apropos of where we are, I think we do get it right in terms of the transparency and disclosing some of these flawed ways in which the government and everybody else has pretty much let them do their thing. In other words, that's why I talk about the history. They made sense 50 years ago. People didn't have data, people didn't have expertise, and they popped up and said, hey, if you want somebody to negotiate for your state employees, we'll get you a good deal. I don't think they play that role anymore. So it's a good question. Stay tuned for the next step, but I think what's in the bill now is a very important addition, and we can build on it. Yeah.
You made a very good point about preventing large increases in drug prices in the future. I didn't hear anything about whether your bill would address the already egregious increases in some prices. Is there any mechanism to roll that back or stuck with where we are?
I mean, a couple of things. First, one of the things I was most pleased about, apropos, and the chairman talked about the savings to the consumer and savings to the taxpayers. The Congressional Budget Office, in their testimony, actually said they think that there is a real prospect because Medicare is such a big player. They're so big in terms of the market. There's more than $500 billion generated in terms of healthcare services each year. They think that this is going to ripple over to the private sector. And that once private sector buyers see, for example, that a pharmaceutical company does not have an unlimited right to subsidies, that that's going to ripple over to the private sector. So I think we're already in a position to start talking about the future. I'm looking, and again, I don't want to front run the chairman, at ways in which we can make sure, starting with insulin, which is such an egregious, example, because, year after year, they'd be getting those rate hikes that would be way in excess of inflation, and you always, watched them, and they basically were doing it because they said they could do it, and sometimes the arguments were just, preposterous. The PBM sometimes would pass on efforts to lower costs, and we'd ask them why, and said, well, it's really going to be good for the consumer. They'll get a larger rebate. And I said, you got to be kidding me. What you're doing is trying to figure out a way to protect, your high list prices. That's what you're all about. So we'll have some more to say, particularly about insulin, starting with insulin, and then I'm looking for ways at being able to look backward, because in everything in healthcare, it's always about the transition. I'll just close with this. I also hope, Maya, that you and your group, and you and I have talked about it, that you'll look closely at ways to modernize the employer-based system. Because, talk about history, the employer-based system was an accident. It came about in the 40s because there were price controls. And in our bipartisan bill, we had a voluntary approach that employers and employees could participate in. But what you ought to do, and I've talked enough to Maya to know, she shares this view, is accept the proposition, and that's why I talk about the Medicare guarantee. Nobody's talking about unraveling that. That was one of the first things the chairman and I said. But consistent with those kinds of values, there are plenty of places, and we've just talked about 2 or 3 others in these brief questions with this young man on this meet. I should be online. That we ought to be looking at, and I'm looking forward to continuing the discussion. Thanks for having me.
Join me in thanking Senator Wyden and Senator Grassley. For those that don't know you, my name is Marc Goldwein. I'm the Senior Vice President here at the Committee for a Responsible Federal Budget. There recently seems to be a lot of momentum around lowering healthcare costs. We just heard about the bipartisan drug pricing bill, but we also have legislation for surprise billing, for introducing new competition from generics, for allowing the federal government to negotiate drug prices. And we have proposals from the administration that really build on and improve even Obama-era proposals to get better pricing and better costs out of Medicare. So our first panel is going to discuss these ideas that are already under discussion for reducing healthcare costs. We're very lucky to have as our moderator Sarah Kliff from the New York Times, who's formerly from Vox.com and one of the nation's top health reporters. Joining her will be Tara O'Neill, Marc Miller, Loren Adler, and Greg D'Angelo. Tara's the Deputy Director of Health Policy at the American Action Forum. Loren used to work for us at the committee and is now the Associate Director at USC-Brookings Schaeffer Initiative for Healthcare, Greg is the Associate Director for Health Policy at OMB. And Marc is the Vice President of Arnold Ventures. Before we get started, we're going to do Q&A by question card. So if you have a question, raise your hand. We have folks that are coming around that can hand you a card. Once you've filled it out, raise your hand again and they'll pick up the card. And now at this time, please join me in welcoming our first panel.
All right, well, thank you all so much for being here. It is, I've been covering health policy for about the past decade, and it's very exciting to see a giant room full of people on a Thursday morning when you could be doing many things here to talk about some of the policies floating around Washington to reduce costs. A lot of the work I've been doing over the past few years looks at how patients are affected by our very costly healthcare system. I've written about MRIs that cost $25,000. I have written about a Band-Aid, an especially expensive Band-Aid that is $629. And I've written about the families who are struggling to pay for these. Just yesterday, I was interviewing a woman in Eastern Virginia who's trying to pay off her daughter's back surgery. She's on a payment plan, and sometimes when the bills get tight, She skips meals. She doesn't eat until dinner because she doesn't want her kids to know she's skipping her meals. And that's kind of the state of American healthcare right now. So I'm really excited that we are here talking about some of the ways that policymakers here in Washington could be both reducing costs for the federal government and for the consumers out there that I'm spending a lot of time writing about. So we have a great group up here who's spending a lot of time thinking about these different proposals. So I will just turn it over to Tara to start us off. Each panelist is going to give us a few minutes summary of some different proposals. We'll get into some discussion. I obviously have a ton of questions. This is what I do all day, but I'll also be taking those question cards from you and asking your questions to the panelists as well. So Tara, it's all you.
Thank you. So I'm going to be talking about the Medicare Part D program, the prescription drug program, and particularly getting into some of the proposals that are out there to redesign the benefit structure. So just to kind of walk through some of the reasons why we need a redesign. In the Part D program, there are two primary components to the federal subsidy. There's premium subsidies and the reinsurance subsidy. The reinsurance subsidy covers costs in the catastrophic phase of the benefit for those beneficiaries who have significant spending and get all the way to the catastrophic. In 2006, reinsurance accounted for 26% of the overall subsidy, split between reinsurance and the premium subsidy. By 2018, it had gone from 26% of overall subsidy to 73%. So you can see there's been a dramatic shift in how this program is subsidized, and that's primarily because there are many, many more costs occurring in the catastrophic phase. And that exposure to these high costs for the taxpayer is hugely problematic. There's been a lot of discussion right about the impact on the federal budget. So that's one thing that needs to be addressed. And then because of changes in the BBA that was passed last year, where the mandatory rebates for drug manufacturers in the coverage gap were increased from 50% to 70%, and simultaneously insurer liability in the coverage gap was reduced from 25% to 5%. Plans now have very limited liability, but beyond the initial coverage limit, which means they have very little incentive to control costs, which of course is problematic. Also, just simply having these mandatory manufacturer rebates in the coverage gap, which is in the middle of the benefit, you have a finite amount of spending which is subject to these rebates, which means you have a maximum rebate that's ever going to have to be paid. And as a result, the mandatory rebate is actually more punitive to lower cost drugs. The maximum rebate next year, if a beneficiary was only taking a single brand name drug, if that drug costs $9,303, they would pay the maximum rebate of $3,698. It's about 40% of the drug's price they would have to pay. But that same maximum rebate would be paid for a drug costing $100,000. So hopefully that shows you how, it's much more impactful on lower cost drugs, and I don't think that's necessarily the intent that we're going for. Further, that encourages higher prices, right? Because then you are paying less as a percentage in the rebate. And then for beneficiaries, as I mentioned, there's over 1 million who reach the catastrophic phase each year who do not have a low-income subsidy. And so they are stuck paying 5% in the catastrophic phase. As Senator Wyden was talking about, there's no cap right now on their spending. And 5% of thousands of dollars, of course, adds up very quickly, particularly for seniors on fixed income. And so there are several reforms that have been put forward. I will quickly run through them and then we'll get into more detail. So one, there's an out-of-pocket cap at the catastrophic limit. Two, and I think one of the most important changes is to move the manufacturer rebates from the coverage gap into the catastrophic phase. And then three, increase insurer liability, both in the initial coverage limit and in the catastrophic phase, while simultaneously reducing the government's reinsurance. I'll stop there and we'll get Q&A.
That was incredibly speedy, thank you. Marc, we'll turn it over to you.
Okay, and just to make you understand how we fit into the environment, we're a philanthropy, we fund research, And then we provide technical assistance to Hill staff, Republican and Democrat, and also to states. We both work at the state and the federal level. I was asked to talk about two provisions that are in the drug legislation, the inflation rebate and then the negotiation process. But just before I do that, people should be tracking, and the senators were saying this as well, how much alignment there is on provisions that are out there. Both in the House and the Senate, committees have passed legislation that helps with competition, that creates and pay-for-play provisions. Both bills have the Part D restructuring that Tara was talking about. Both bills have an inflation rebate, and then the House bill has the negotiation, and the Senate bill does not, just so you know how things line up. So with respect to the inflation rebate and negotiation, I'm trying to tell you two things. Potentially what motivated it, and again, I'm providing technical assistance. I don't know what's going on in these people's heads, obviously, and then how it works. And so the issue with the inflation index, I think in particular springs from, in Part D, the fact that the beneficiaries' deductibles and co-payments are tied to list prices. And as the senator said, list prices have been accelerating very, very rapidly. Insulin is a poster child for this. I think there's also frustration that says that launch prices are increasing year after year and are justified. I don't buy the argument outright, but justified on the basis of R&D, recovery in R&D. Why do you have to inflate past that point repeatedly year after year when the quality of the drug or the drug is not changing? So I think you have, and then finally you have some odd competitive structures in Part D where you have competitors in theory, insulin, there's 3 brand name manufacturers, yet the prices continue, at least list prices anyway, continue to escalate. And I think that's what brought people around to an inflation rebate. The inflation rebate applies both to Part D and to Part B in Medicare. The way it works is you look at the list price. The 2 different bills use a different metric of measuring list prices, the AMP and WAC, for those of you who know what that means. And for those of you who know what that means, I'm really sorry that you spent your life knowing what that means. But if you use either of those metrics, how those metrics go up relative to inflation, and then the difference is rebated back to the government. And as the senator said, that's being used to change the benefit structure. The 2 bills are a little bit different on the base year that they start and measure it from. One has been scored. The Senate bill has $57 million in savings for Part D and $11 million in savings for Part B. And I'm assuming since the sponsors of this are the Committee for Responsible Budget, you guys want to know what the savings were. Okay, so then that brings us to the second provision that I was asked to talk about, which is negotiation. And I think some of the rationale here is this, is that the federal government grants patents and market exclusivity periods, and then a manufacturer has the ability in that without competition to set prices where they see fit. And I think the negotiation portion of this debate is aimed at drugs like that. It is directed to drugs that don't have competition. Those are defined as sole source drugs, no generic, no biosimilar. The criteria is to look at the top 125 drugs in terms of spend either in Part D or nationally, and that's the pool of drugs that the Secretary can negotiate around. The Secretary is required to do at least 25 drugs per year, and insulin is, I believe, included in the first batch. The negotiation is bounded by 120% of an average international price based on 6 countries, and then at the low end, the lowest price for a drug in any of those 6 countries. So the negotiation occurs within a lane, if you will. The second thing is that I think the people who put this together didn't want to ever take a drug off of formulary. They wanted all drugs to be available. And so this corridor and then a penalty if the manufacturer either doesn't negotiate or doesn't come to agreement with the government, a very hefty excise tax on sales sort of enforces that the negotiation will occur. And I think it's those two provisions that actually change CBO's perception, because for years they would not give credit for negotiation, but these two structures, I think, changed their thinking. But again, you'd have to ask that. Okay, these prices apply to the commercial market as well. And this was scored at $345 billion in savings for Medicare. About 300 of that is program, the rest of it is beneficiary. And I don't have the estimate, but the CBO says there are savings on the employer and the household side of the market. And the Office of the Actuary also has estimates and says that as well. I'll stop.
All right, thank you, Marc. And now, Loren Adler, I think, is going to talk about something a little different from drug prices, the work that's been happening around here around surprise billing.
Yes, thanks for having me. So I'm here to talk about, I think, one of the more glaring market failures, and in some ways a sort of simpler fix than drug pricing, maybe, to try to address here in Congress, and also a very bipartisan issue. And I see a lot of people in this room who've seen me give this spiel before, but I'm going to do it in 4 minutes right now. So just to kind of give the broad overview, right, these surprise bills happen when sort of two main circumstances. So, right, you're in an emergency, you call the ambulance, they take you to the emergency room, and they even take you to an in-network hospital, but it turns out the emergency physician or whatever physicians that treated you during your care were not in your insurer's network, or the ambulance was out of network, which is an all too common experience that Sarah actually has written on a bit. Or the other one is even sort of for elective care, where the patient does everything right. So, you can be very pro sort of shopping and transparency, but no one knows to look that like the anesthesiologist is in your network. And even if you did, try figuring that out. So, when you go to deliver a baby, you can make sure that the OB is going to be in network, you make sure the hospital's in network, but the anesthesiologist who actually administers the epidural, there's no real way to actually check that. They can be out of network. When this happens, the insurer will pay something to that provider typically. Usually they'll pay something around what they would have paid in network, but then that provider can then turn around and balance bill you for the difference between what the insurer paid and their sort of made up list price that is just sort of this sticker price that is like, sort of like the MSRP on a car, just completely untethered by market forces, and they can just charge you for that difference. And obviously that can be cause very significant financial harm. And I think, we always talk about anecdotes, and there's a bunch of reporters in the room who've written about all these sort of big anecdotes here, but this is really more than just a series of anecdotes. But I think we now have enough data to know this is actually like a pretty common occurrence where this happens. So, and from the data out there, about 1 in 5 times that you go to the emergency room, you are going to be seen by an out-of-network physician as part of your care. 1 in 10 times that you schedule elective care with an in-network surgeon or something of the sort, you are going to be seen by an out-of-network, one of these sort of ancillary providers, like the anesthesiologist or the radiologist. That's just very common. Obviously, not in every circumstance are they actually sending the balance bill. But that's a lot of times where the patient sort of gets stuck in the middle here. And then just sort of to add insult to injury here, right? It's not just that people are getting these big surprise bills, but it's that a subset of the physicians in these specialties are leveraging the threat of surprise billing to get, and typically it is often the case being private equity companies who are sort of moved into really sort of dominating these specialties. They then use that leverage. They tell the insurer, I will surprise bill every one of your enrollees unless you pay me a boatload of money to come in network. And so when their rates are very high in network, we all pay higher premiums. That's what, all of us in commercial insurance coverage for our employers are all paying higher premiums as a result of this problem, which is why the safer position is why sort of you get budgetary savings when you're sort of addressing this issue. I think sort of put simply, the sort of ideal solution here is it should just be illegal for an anesthesiologist to be out of network at an in-network hospital. Like, that's just sort of insane that you can go to an in-network hospital, do everything right, and then like the doctor who had no idea was going to be part of your care honestly I tried with my wife gave birth to figure out if the anesthesiologist was going to be in network. It's a fool's errand. I called 8 different people. I got thrown around and never actually found a firm answer, just sort of hoped I was right. And luckily, we got lucky, but still, that's not exactly like a way to run the healthcare system. I think at that point, you've actually solved everything. The market will then take care of what people get paid. Everything, the entire policy debate is sort of how much to then sort of put in an artificial price support on how much physicians should then get paid after that. And just sort of, and leave other things to Q&A, but I will at least mention right now there are 2 bipartisan bills that have passed out of both the Health Committee in the Senate and the Energy and Commerce Committee in the House that are compromises from my sort of ideal vision here, but I think are still policies that at least get at the market failure and move the ball forward. Now pass it over.
Thanks, Loren. So I'm Greg D'Angelo with the White House Office of Management and Budget. I was asked to come here clearly to speak about the President's budget proposals and Medicare, and there are a few things I kind of want to highlight on the front end. As you probably saw when we released our budget this year, we were charged with the notion of cutting Medicare $845 billion, which is something we thought was entirely false. And you'll see actually when I walk through, there are a variety of proposals that have been bipartisan. So we're a little bit shocked about that, but we're very appreciative of the opportunity to come here today and talk about some of our proposals, and thank you for this initiative as well to start a bipartisan conversation. So our budget proposal actually included about $500 billion in Medicare savings. We all know Medicare's fiscal outlook is challenging. The HI trust fund can go insolvent within a few years. By 2026, our proposals would extend the life of the trust fund at least 8 years. Over the long term, Medicare's unfunded obligations are about $42 trillion. And so Medicare's financial situation is pretty dire. So that's why it's important to have this conversation now. And if you look at our proposals to strengthen Medicare's finances, we've done this through protecting benefits for seniors and improving the program for beneficiaries, but mainly by finding efficiencies in the way that we pay for care and finance care. In total, our proposals would have reduced the rate of growth in Medicare spending by only about 0.5%. So, say that again, under our budget, Medicare spending would go up each year, right? Just at a slower rate. So, 0.5% reduction. Total savings in our budget relative to baseline projections actually on average was less than the last 5 years of the Obama administration's proposals in the Medicare space. And so what we were doing was somewhat in line, but not even as aggressive as kind of the previous administration. But again, as I mentioned at the outset, we were sort of charged with cutting Medicare by $845 billion, which we believe was inaccurate. In particular, I'd like to highlight some of our proposals. In addition, we had prescription drug proposals, Medicare Part D. I think others have already commented on that, but I want to note that the President was pivotal in starting that conversation on a bipartisan basis. We had Part D structural reforms in the last 2 budgets of ours, so we really think that helped jumpstart the conversation on both the Democrat and Republican side, and I want to applaud the chairman and ranking member for all of their great work in this area on a bipartisan basis. But in particular, I want to focus on our proposals in the budget to reform provider payments, address wasteful and unnecessary spending by incentivizing quality and efficiency of care within the current system. So as ranking member Wyden said, no one's talking about changing the guarantee, taking away benefits. We're talking about paying for care more efficiently and more effectively in a common sense way. So the concept where there's broad bipartisan agreement is essentially around site-neutral payments. So these proposals are supported by nonpartisan experts. They remove payment disparities that result in higher payments to hospitals based on the site of care and not the clinical needs of patients. So what we're suggesting here is paying providers appropriately based on clinical need, not the location of service. Again, that notion, that's not a Medicare cut. That's being smart about how we operate the program and how we pay for care. There are 2 particular proposals we had that were significant, creating a single site-neutral payment for post-acute care, as well as paying for certain outpatient hospital services using the physician fee schedule. Look forward to talking about those in more detail, but I want to note that the Committee for Responsible Federal Budget, at the time we released our budget, did accurately note that 85% of these Medicare provider savings were actually contained in the previous administration's budget. So again, this is some area where we think there'd be bipartisan agreement. Almost in the media got this wrong. I will note as well that New York Times editorial board was one of the outlets that got it right there as a correct, as well as the Washington Post, and gave folks on the other side, two Pinocchios for criticizing us. I won't pull out some of the quotes I have. I mean, these cuts were cruel, and we were going to let Medicare win their own line. That was unfortunate. I think I'm here today to say we look forward to having an honest bipartisan conversation about these types of common sense reforms and protecting Medicare for beneficiaries on the program today. The President recently released a Medicare executive order, and we're going to take a series of administrative actions wherever we believe we have the authority to do so. In fact, we have already tried to take action in a few areas to promote site neutrality of payments, but we're blocked by the courts. And so we're continuing to plow ahead, whether it's with Congress or where we think we have the authority. And so we're committed to the principle where, we think there's bipartisan agreement on paying for care based on clinical appropriateness, not based on the site of service. So with that, I'll kind of close and basically say for questions, having an honest conversation.
Thank you, Greg. Thank you all of you for those opening remarks. I will remind you, if you have a question, I am more than happy to ask it. There are cards available from staff members. If you don't have one already, just raise your hand and they'll be bringing them up to me. So let's go back to drug pricing where we started. It seems like there is pretty widespread agreement that something needs to be done to redesign Medicare Part D for a lot of the reasons you outlined. And senators are working on it, but there's also a number of other proposals. So I was hoping, Tara, others who want to chime in, if you could talk through what are the big key differences in the different drug proposals that are floating around right now, and how would they kind of lead to different outcomes for the patients who rely on Medicare Part D?
Sure, so I'll first talk through some of the differences in the Part D redesign proposals that are out there. So AAF last year put out a framework outlining a way to redesign the program that both, I think, the Senate Finance and HR 3 bills, they're similar to, but of course the parameters are pretty different and there are significant impacts in those differences. And so the proposal that we put forward, we suggested having 9% manufacturer liability in the catastrophic phase. And the reason we went with 9% is because that is what Milliman, an actuarial firm, did modeling and found that 9% would be budget neutral under current law to the pharmaceutical industry as a whole. Basically, if you look at the next 10-year window, that they were scoring, under current law, manufacturer rebates would pay X amount of total dollars, I don't remember what that number is, and if you moved the rebate from the coverage gap into catastrophic, at 9%, they would pay the same amount. Obviously, there's differences by company and who would pay those amounts, but from an industry perspective, it would be budget neutral. So then when you look at the finance proposal, they've gone from 9% where we were to 20%. So they've more than doubled the impact that the pharmaceutical industry will feel. So they'll be paying twice as much rebates as they're currently paying today. And again, we're just talking about the mandatory rebates. We're not talking about any voluntary rebates that they also pay. And then the Pelosi HR 3 bill goes from 20% catastrophic up to 30%. And in addition, they have 10% liability for manufacturers beyond the deductible, which in 2022, when this would go into effect, is less than $500. I think it's supposed to be about $485. So every drug that a beneficiary takes after they've had $485 worth of spend, they would have to pay at least 10% of a rebate, and then when you get to catastrophic, 30%. And when you tally that up, that means that a manufacturer would pay about 3.6 times more than what they would pay under our proposal. So of course there are significant impacts there in the amount of revenue that drug manufacturers receive, and there could be significant impacts on the innovation that we see as a result, and new drugs coming to market could be significantly declined as a result.
So, and your question is kind of where they're together and where they're apart, I think. And so, just one more time, there are provisions out there out of the committee in both the House and the Senate on creates and pay for delay, where it seems like there's fairly high alignment. There was some brief discussion on the part of the senators about some transparency, both in terms of the PBMs and the manufacturers. I wouldn't be surprised at that. You could have pretty high alignment on. Then you get into the Part D restructuring. And remember that the fundamental concern here is that with an 80% current liability for the federal government when someone goes into catastrophic cap, there's a real sense that the program encourages using high-cost drugs instead of low-cost drugs, because you hit the catastrophic cap, the government pays, you get a rebate, what's the problem, that type of thing. And so there are back and forth about the insight of this policy is it puts the manufacturer and the PBM at risk once you cross over into catastrophic cap, and there's dickering back and forth about how much of that risk should be held by the PBM, the manufacturer. There's agreement, and the federal government. I think they will never go below what is under current law, and then they'll work something out, between those two bills. My sense is that there's pretty high alignment between the parties on that. On the inflation index, it's in both the Senate Finance bill and it's in the House bill, but the support in the Senate on the Senate inflation rebate is very shaky, and I think the most fiery point in Senator Grassley's remarks was when he was talking about the need for other Republican senators to kind of realize what's going on and get on board. But that has not happened yet. And so early on I said the two bills are aligned on that basis, but you should know that the support on for the Republicans among the inflation index is shallow. I'd be interested in hearing what the White House's position is, and that was directly to put you on the point. In case you're wondering. And then, honest dialogue.
Fair enough. So you could check Twitter. I think the president is in support of Wyden, Grassley, and
I was
our
hoping
process and product they have there.
I would hope so, because I think the president could make a huge difference on this particular provision. If the White House spoke to it, I think it could make a big difference. So there's that. And then the last thing is the negotiation piece, and you should be very clear about this. There is very little Republican support for this on either side of either House or the Senate.
Greg, do you want to speak to the inflation rebates a little bit and kind of how the White House thinks about them?
Sure. So as you're aware, our budgets, the last two budgets have had inflation limits on Part B drugs. And so Senator Wyden, as part of the negotiation with Senator Grassley, had advocated for imposing an inflationary cap basically on price increases in Medicare Part D. It's a much more controversial idea on the Republican side, given the private sector structure of the Medicare Part D benefit. That was a key piece of this bipartisan compromise, and we're supportive of their deal. Again, we think we need a bipartisan product. If this is the thing that makes it bipartisan, if this is what's necessary, I think we've indicated that we could support it.
Is there anything else you want to add on the prescription drug space, or not to keep you on the spot? Well, let me.
I think Chairman Grassley, I think, said it best. I mean, like it or not, the House bill would not have 60 votes in the United States Senate. I don't think I'm being confused there. And so I know the Senate's not. I've worked in the Senate for nearly 10 years, but if there's a bipartisan deal, it's going to be done in the Senate, not going to be out of the House.
So I just wanted to add one comment on the negotiation piece, on the inflation piece in Part D. Both Marc and Greg talked about the Republican opposition in the Part D space, particularly, whereas there's less opposition in Part B. And as Greg said, I think a lot of that is because Part D is a private sector program. It's run by private insurance plans, and so there's a lot of support for maintaining this private sector program. It's working well in a lot of cases, but in some cases it really isn't, as I have walked through. And I would argue that there is one piece in particular where I think the program is really not working well, and it is exactly because of government interference, and that is the protected classes, which every insurance plan has to cover every drug in the 6 protected classes. And so you really have limited the market's ability to negotiate on those drugs. And so I think if you're looking for a compromise, I would say, at least in the protected classes, you need to have an inflation to because there's the study that has been done that has shown that in those classes, drug prices have increased almost 40% above inflation over the last 5 years. So there's clearly a market failure in regards to those drugs in particular.
Something you brought up, Marc, that I find really interesting is the idea of using some kind of international reference pricing and using that as a way to constrain our drug pricing. And I was hoping maybe Greg could weigh in a little bit on how the administration feels about that idea. And I was hoping you could talk through a little bit more, how ironclad do you feel like these penalties for not negotiating are? Because I think one thing that comes to my mind when I think about negotiating around drugs is each party to have leverage needs to have the ability to walk away and say no. In some cases, you could mean a drug getting dropped from the formulary. You see things like this happening in the National Health Service in Britain. How do you think about how much leverage the United States would be bringing to the table in those negotiations?
All right, so I think there were two questions. You were asking about the international price first, and then the leverage of the penalties. Is that
Yes.
the thought process? So I think if you have open-ended negotiation and no corridor, no tether to it, the one reality is that you wouldn't get a score out of the bill. I think, and I'm sort of speaking a bit out of school. So then I think the thinking went to, well, if you're going to tether it, what do you tether it to? And there's conceptually a few things you can do. One is the cost of producing the drug, and that is very controversial and also very opaque, okay? Number two, you could say the value of the drug using some metric, say created by ICER or an independent organization like that, and say I'm going to price to that. But that's also extremely controversial. And then that brings you to the third one, and I think Gregory's point here is very relevant, is the president said a couple years back, why does everybody else get a better price? That has a lot of traction, I think, in the political sphere. I'm not a politician, but my sense is it did. And so that drove the linkage to the international price. I think it's not, none of them are perfect, and I think there are issues, and I know you know this. I mean, this will drive increases in the international prices, and it will definitely drive increases in attempts to kind of hide the wall on what the actual international price is. So there'll be issues there, but I think as a pathway forward, it was the one that was really open to people who were thinking about this. If the penalty is enforced, it is a huge club. 95% of your sales in the United States is a lot to walk away from. This is a gigantic market. Next 10 years, this is a $7 trillion market. That is a huge club, if it's enforced.
I'll take those two questions in turn. I think the first one was on IPI, international pricing. Fortunately, the proposed rule of IPI is under review at OMB, so I can't comment on the substance or timing, as it's under review. However, I can speak more generally about the president. He's been very clear about ending the problem of foreign freeloading. He doesn't think it's right that Americans are paying for all of the research and development, and then also paying higher prices. And so I think in any drug pricing initiative, whether it's legislative or regulatory, I think he has set out that larger goal of ending that disparity between what we pay and what others pay in terms of drug prices. With respect to the House bill in particular, you're referring to the leverage of the penalties. I mean, I think this is where the rubber hits the road. I mean, we don't think that it's a choice, the negotiation. We think it's mandatory, right? If you're to lose 95% of your revenues in sales of drug potentially for walking away from the table, you can't. It's not a voluntary negotiation. It's in effect a price control, and that sort of sets aside even the entire apparatus for effectuating this negotiation. The process, we believe, would be too complex, too complicated, and unwieldy. Essentially, the CBO scores clearly propose $3 billion in compliance costs in the private sector, and CBO hasn't even looked at what the direct cost would be to HHS for actually implementing the provision, and it's unclear to us if that could even work.
say that aside, I think Chairman Grassley was pretty clear. You know, at the end of the day, there are 60 votes for negotiation in the Senate, so I think the policy merits are important. We should discuss those, but it's dead on arrival anyway. It's, you know, unclear why we're wasting so much time talking about it.
I'm just saying, I mean, people can quibble with whether it's negotiation or price setting in the sense of the work, but there's also nothing that, if you nominally call something negotiation, but there's no hook on the manufacturer to participate, then it's not negotiation either, because the manufacturer has no reason to come to the table. We think of this is what we call negotiation in other countries, but there is still, the negotiation is over whether the drug company can still say, I refuse to sell in America, or try to drum up political pressure to get the government to pay higher amounts. Right? That's sort of what the negotiation, that's the manufacturer's vote, not actually needing 95% of the sales cut. That's not what they're actually going to do. Obviously, that is a lot of leverage in the U.S. government's hands. Not going to dispute that, but that is what we've always sort of called negotiation. And I don't know, without the hook, there's no negotiation either. So I just always sort of interpreted that. I mean, just to sort of throw a little bit of excitement into that. I mean, it's true that there are probably no Republican votes for H.R. 3 in the Senate right now, but you know, I do think a vocal Trump support on this might change that, which is sort of, I mean, obviously it's a big ticket item in campaigns and everything like that, but I think it's a little bit naive to say that there's no Republican support without ever trying to put some presidential bully pulpit force behind it.
Okay, so let's talk about a topic near and dear to my heart, surprise billing. Loren, you spent a lot of time looking at the different policies that are floating around here. We've seen a lot of them play out in the state. I looked at New York uses an arbitration model, California uses more of a rate setting model. Can you just talk through what these different approaches are and what different outcomes you would expect if we go down one road versus another?
Sure, happy to jump in here, and obviously I think White House sort of given proposals on this as well. So you're right. So there's been there's a lot of different proposals out there. There's really only 2 different paths that any state has actually taken and that are actually being considered in front of Congress right now. As I sort of mentioned, the key aspect of actually changing the underlying dynamics in the surprise billing is just saying it is now illegal to send a out-of-network surprise bill to a patient if you're that anesthesiologist at an in-network hospital. That is that's the club, that is the thing that actually changes that's what fixes the market failure here. After that point, we're really just talking about how much of a sort of artificial price support, minimum wage, however you want to think of it, to sort of force feed, so make that we're kind of going to increase costs to kind of provide this sort of minimum payment to providers. And that's where you get to this option of whether we're going to call it a benchmark or like in the California law, or we're going to use this sort of arbitration process so we can kind of feign that we're punting this to this outside decision and pretend that we're not making a decision when we effectively are. All arbitration does, there's nothing magical about it. All it does is we just sort of say, we tell the arbiter, here's a rule of thumb you should consider. You should choose, a rate closest to X. And that's what we see in every arbitration system out there. They come up with a rule of thumb and they go, okay, so New York has like a really inflationary rule of thumb where they say, you have to choose whichever rate is closer to the 80th percentile of bill charges. And so that's that list price that's sort of like made up crazy high price. So they don't force you to do that, they just encourage you to do that, and that is what we see in New York happen. I think that is sort of a pretty clear recipe for a pretty inflationary impact, at least from like linked CBO scores. That seems to be, CBO sort of applied something similarly here. I think that's sort of pretty clear, but that's not because of arbitration per se, that's just because they told the arbiters to consider this sort of very high rate in New York. The arbitration proposals being kicked around Congress do not do that. Well, sorry, the one in the Senate does not do that, I should say. There's a House version that is just like the New York one. My main point is just that arbitration, there's no like policy rationale behind it. It's just sort of a way to sort of kick the key into someone else and have some administrative costs. And I think my biggest fear is to sort of make the process more opaque. And you don't know what yes, most likely they will stick to the rule of thumb you give them, but that's not certain. And I think the odds are much more likely that they get captured by providers than the other way around. And in this circumstance, this is very much, we talked about this is very much a bipartisan issue. The divide on this one is very much sort of patient and employer groups being sort of pitted against, largely private equity companies, but also provider groups who have been benefiting from the status quo. In this case, right, providers sort of getting, anesthesiologists sort of getting a higher minimum wage here means that we're all paying higher premiums as a result.
Yeah, and you go to,
I mean, remember, you also, even if arbitration worked well, and I completely agree that you probably get a drift and capture over time that makes it inflationary, you still have imposed an administrative cost that everybody has to pay on top of that. If you go to a benchmark, you're probably driving more of those negotiations in network and potentially have some effect there that could be positive.
I just want to add, following what Loren said, thank you for mentioning the White House's role here. As a reminder to folks, the President released principles basically on surprise billing and ending surprise billing and called on Congress to act this year. And so we haven't endorsed any one particular proposal, but we've set out from the beginning, our principles for the type of reform we could accept, and haven't had, from hard lines in the sand, but we still think this is something that Congress can get done this year. There are active negotiations we're engaged on it, much like the Part D redesign. I think the President has played a leadership role in prompting this discussion.
Just to drive home the point, just because I didn't really talk about what's actually in front of Congress a little bit. Right, I think we talk about this sort of, everyone has a different name for it, but the sort of benchmark proposal, which is very much what is in front of what got passed by the Health Committee, what got passed by Energy and Commerce, and other bills that have floated around are sort of similar here. I do think, you still are sort of saying, you're still sort of setting an artificial floor on how much the anesthesiologists get paid here, but there's a lot of scare tactics going around about proposals like this. I do think it's worth noting that we've looked into this a little bit in California, which has a pretty similar law to the ones being considered federally, that there really does seem to have been a very big shift in network in California after their law, which I think is important because all the sort of scare talking points are that this is going to lead to access to care problems, everyone's going to go out of network, and people are going to start dying. There's a lot of very heated rhetoric around this, but so I just think it's like worth looking at the evidence a little bit here, but I think it's pretty clear that there haven't actually been adverse consequences from that, and obviously it fixed the actual fundamental problem, which is what we're trying to solve here.
If you'd like to read more about California's law, read about Loren's research at the Times, and it does show, folks moving in network and no huge scary consequences. We're just wrapping up. We only have a few minutes left of our panel. So I want to put one question to you all about a proposal we haven't talked about yet. This came from the audience, is the new price transparency rules that came out earlier this week. And I'm curious how you guys, I know this hasn't been in our discussion yet, but what is the role of price transparency? Could, these rules would make the negotiated prices between insurers and hospitals public. Is that going to lead to cost savings for the government and for patients? All right, Marc, why don't you start us off?
Just go for broke.
I want to say this is a very constructive idea. Notwithstanding my response, this is a very constructive idea. It should be part of what goes on in and of itself. Just knowing what prices are is not going to result in the kinds of change.
What we would say is, it's a necessary first step in order to have a marketing of information, right? We want to promote market-based courses and have more choice and competition, and so it's a necessary condition. And without information, we're not going to have more competition. We don't have hope of reducing costs, so it may not be a silver bullet, but I'm not sure any one of these ideas is in healthcare. It's just also a common sense thing that patients have a right to know what the price of services are before they receive care.
Yeah, I just sort of tack on interestingly, right, so they finalized this rule as sort of hospital-focused price transparency recently, but there's also a new proposed rule that got proposed on sort of the forcing transparency from the insurer side. I think there's actually a fair amount that can be done administratively on the sort of, almost building all payer claims database-esque things with the sort of 1315, there's administrative authority to sort of use that, I think, from my very novice legal hat, also seems a little bit easier to get through the courts as well.
And And these rules, if you all don't know, stem from an executive order the president signed earlier this year. So again, it's another issue where the president and the Republicans have taken a leadership role in healthcare and moving the conversation forward.
And I would just add one more thing, particularly on the hospital side. Again, similar to Marc, I mean, price transparency can be great. It's not likely to move the needle, particularly when you think about the fact that the majority of hospital markets in our country, there's a single system. There is no competition, and so it doesn't matter if you know what the price is, if you just have to pay that price regardless, right? Like, you don't have a choice. And so that's where we are afraid it's going to be very ineffective. And so while it might provide some benefit, it's going to, shine light on things, that obviously is good, but it's not enough in itself to actually be effective in bringing down costs.
I always love Kara.
This is it, because, no, she's absolutely right. I mean, most of the hospital markets in the country are monopolies. You'll just know you're being hammered. And if you don't take either some action on regulatorily, and then people are hoping that people will start shopping, but I think that is going to be, that's a bridge that's a long way off. So the positive part of it is at least people will know, and maybe policymakers will do something about it.
Greg, I feel like I should let you, do you want to respond to all the illustrations
It's just a
presented?
disagreement on the strategy. I think we need to take step-by-step reforms. We're not going to reform the health system in one fell swoop, but we're going to do what we can with the authorities that we have and push Congress to move where we need them to move. But, I think it's maybe a philosophical difference. We're not going to have one big bill to reform the entire health system. And, I think that we pass something like that out of Congress. And so I think we're going to do what we can with the authorities we have to move the needle.
All right, great. Well, thank you to our panelists for this discussion. And Marc, welcome.
We are going to forego our break and just keep this event moving. So for those of you that need to use the facilities, you'll have to miss some of our awesome panel. The last panel we talked about ideas that are currently in place to lower healthcare costs, and they're really important. But they're not really sufficient. We also need new, innovative ideas to lower health costs, and that's one reason we're so excited to have recently launched our Health Savings Initiative, a joint project between the Committee for Responsible Federal Budget, the West Health Policy Institute, and Arnold Ventures. A key goal of this project is going to be come up with the next generation of ideas, the new ideas out there that can take that next step in lowering healthcare costs in a variety of ways. And to get us started, our second panel is going to have some discussion about where those ideas might lead us, where this conversation might lead us. The panel is going to be moderated by Timothy Lash, who is the president of the West Health Policy Center and Chief Strategy Officer at West Health. It's also going to feature Holly Harvey, Michael Chernew, Niall Brennan, and Chapin White. Holly Harvey is our Director of Health Policy here at the Committee for Responsible Federal Budget. Michael Chernew is the Director of Healthcare Markets and Regulations Lab at Harvard Medical School. Niall Brennan is the President and CEO of the Healthcare Cost Institute. And lastly, Chapin White is a Senior Policy Research at RAND. Again, we're going to do questions the same way, so if you have one, raise your hand and we'll come around and give you a card. But please join me in welcoming our second panel.
Okay, here we go. Maybe we'll try to keep this a little bit bouncy back and forth on issues. As I reflect on the previous panel in terms of current health policy, you have to ask the question: are there room for new ideas for containment? And I thought the conversation around prescription drugs was particularly illuminating. But it's clear that there's room for more. The West Health Policy Center just released a study that looked at return on capital investment in the pharmaceutical sector. And you could strip $1 trillion of annual revenue out of that sector, maintain R&D at the same level, and it would still be the most profitable segment of our economy. So there's certainly room to do more here. As I think about new ideas for cost containment, I think there's two areas that at least I sometimes struggle with. If we reflect overall about our healthcare system, it's not actually clear where we're spending too much and where we're spending too little. That takes data to really understand. I think freeing that data has been historically difficult because it's seen as a competitive advantage or a means of control. I think if you move to the policy side of things, I think there too we've had challenges in understanding what works and what doesn't. And if I just reflect on my own career, certainly I've learned more about the things that have not worked, and hopefully that resonates with the rest of you all as well, than I have with the things that have worked. And the New York Times recently published a piece estimating that we spend less than 0.1% of our overall healthcare expenditure on understanding what health policies actually work. And I have to tell you that figure is somewhat shocking to me in that I think it's probably too large. That the investment is likely even less than that. But there are some pretty conspicuous examples of what's not working. And Arnold, before we get into the Health Savers Initiative, I just want to talk about a few of them because I think if you understand what's not working, perhaps that informs what are some of the characteristics of health we're going to partner on this project to develop new policies for cost containment that could work. So, four areas that initially come to mind. One, there's been so much discussion of value-based care, and yet we just simply inch along year over year, towards it, and it's largely still aspirational. I think we've had very little success, and this came up on the previous panel, of balancing the purchasing and supplier power. We have these geographic monopolies that are popping up across the country on a regular basis. I think often the conversation has focused on the public sector, and have we failed to ask the question, what public policy might be able to support the private sector to accelerate its transition to higher value care? And perhaps, the most striking to me is that somehow we just get paralyzed by these myriad of political and economic and provider incentives and priorities where we get stuck on, with this policy, it will be awful care, it will be low quality care, and you all are going to die immediately, right? And that's just not the case. Senator Grassley highlighted at the beginning a recent West Health Gallup survey where we looked at perception around mortality, and he had indicated 34 million people know someone that passed away in the past 5 years after not being able to afford the medical care that they need. Underneath that, what's even more striking, that's just north of 13% overall, if you look across the U.S. But if you look at non-whites, it's almost 20%, right? And it's just in the richest country in the world, it's something that we shouldn't have to tolerate. 54 million Americans not being able to afford their prescription drugs in the past year, and $88 billion now being borrowed annually to pay for healthcare expenses. So, just tolerating the status quo, it's unacceptable, really, and I think it's irresponsible, which is why I think, we are, just delighted to partner with the Arnold Foundation and the Center for Responsible Budgeting to launch this new collaborative, action-oriented, initiative. And I guess, with that, Holly, then we'll jump into some of the areas, and we'll touch on prescription drugs, but we're really going to really focus on opportunities within Medicare. Let's look at prices. I mean, they're really high, and then the employer and employer segment. But as a foundation, Holly, what can we learn from what hasn't worked that perhaps will inform a brighter path forward for some new opportunities in cost containment?
So, I think it seems like something is missing, right? We've tried to, for the past 20, 25 years, I've been in Washington, and there's been a lot of talk about aligning incentives and financial alignment between providers having the incentive to provide more efficient care, and yet that formula has not produced lower cost care. And I think one of the exciting things that I see is that there seems to be more and more recognition that this, what we would expect in a functioning market, is equilibrium and this balance of power between various interested parties is out of balance. And so we
trajectory of national healthcare expenditure versus some of the current and more aggressive policies, right? Or policy proposals. Are they congruent, and if we're bold enough, or how should we think about the magnitude of new policies relative to the need for containment?
So, I guess first let me say something about the need for containment. If you go to national healthcare spending, I think the system will collapse on not only healthcare. My name is, it was so well received that never happened. What I was saying is, if we don't control the rate of healthcare spending growth, I think the system will collapse. Not just the healthcare system in some ways, but much broader impacts on our economy. So I think there's an incredible imperative that we do a better job. And getting us from 4.5% growth to 4.2% growth is important, but you're not going to survive 4.2% growth if your income is growing a lot less than that. So we have to figure out how to do that. There's no question. I think it's absolutely clear. The second thing I would say, and it's nice, I don't spend a ton of time in Washington, it turns out that everybody's spending is someone else's revenue, and so I think part of the problem is we have to actually want to have lower spending. Everyone wants to have lower spending, but let me say, you have to actually want people to get less money than the other one. That's the way spending works. Someone gives money, someone gets money. We don't have to lower the amount of money they're getting. We have to lower the rate of increase in the amount of money different groups are getting, one way or another. And I think it's imperative that we do that. So I think you'll ask a lot more questions on how to go about it. My general view is that, although we can talk about a lot of new ideas, my guess is the solution that will come will be pretty close in spirit to many things we're either doing now or talking about, and we really just have to begin to execute better. So later we talk about this thing and a bunch of other things, but I think it's really about a bit of patience and hard work to get the details right, and to really, really, really increase the actual willingness to do something.
So grow into a new baseline. As we grow into the new baseline, are we being bold enough today?
No. To build on Mike's comments a little bit, I think one of the problems is people, including established stakeholders across health policy, they love to talk about healthcare reform, but they approach it from a perspective that somebody else is going to suffer, or somebody else is going to give up the revenue, and then the cost curve will magically bend. And I think until people realize that really addressing cost containment is going to require sacrifices across all stakeholders, we're really not going to make a lot of progress. And so because people don't want to have those difficult conversations, we default to friendly, optimistic buzzwords like value-based care and patient empowerment and things that really ignore the elephant in the room, and the elephant in the room is spending out of control.
Often it takes, terrible economic, political, or global circumstances for people to, accept the fact that, there's going to have to be some sacrifices and trade-offs here. Have we reached that threshold? Do you think the environment is conducive to, to advancing legislation that does just that?
Not really. I think that employers, I've been surprised at how not angry employers are at the situation, given that the vast majority of Americans still get their health care through their employer, and that is the one single area of the healthcare systems where things are operating at their most constrained. I think we can agree that there's been progress in Medicare and Medicaid, but on the employer side there's not. So I think until employers really band together, whether it's as a group or from a lobbying perspective, and say that they're not going to tolerate these types of price increases and shrinking benefit packages, and price increases and shrinking benefit packages with really morally objectionable things hidden in them, like surprise billing. We're not at that point yet.
Schaeffer?
So what's not working? That's easy to tee up. So let's see. Let me back up. In the Medicare program, we've got MedPAC, we've got CBO, keeping their eye on the ball, we've got bipartisan proposals on the table. Medicare is in the mode of tinkering with, and they've got all the cards on the table. And Medicare spending growth per beneficiary has been below inflation for a long time. Medicare is doing pretty well. What's not working is the privately insured. Folks in employer-sponsored insurance, that's where most of us get our healthcare coverage in this country. Folks in employer-sponsored insurance, their plans are paying prices to hospitals that are growing at 5% a year, and that is leading to premiums for employer-sponsored insurance that have broken through the $20,000 mark for a family this year. That is not working. And let's try out an idea for addressing that. To me, there's a very simple solution, which is set a limit on how much providers can be paid for treating privately insured patients if they're out of network. This is the surprise billing idea, but rather than limiting it to these surprise billing situations, apply it to non-emergency care, apply it to facilities. That will affect the negotiations between private insurance plans and providers. It could have a profound impact on our spending trajectory, and it gets at a huge segment where the equilibrium is missing. Now, is this a new idea? No, this is not a new idea. This is in effect in the Medicare Advantage program.
Mike, you have thoughts on this?
Well, I will take it to finish what you've done.
Yeah, this is an old idea in Medicare Advantage. If a patient goes out of network, the provider gets paid the Medicare fee-for-service rate. Now that, you don't necessarily have to apply that, but the California surprise billing approach says take the median in-network rate, take 125% of Medicare, pay the greater of those two. That's a nice blend of Medicare-based benchmarks with in-network with negotiated rates. Apply that beyond just the surprise billing situations. Surprise billing is morally offensive. It gets people riled up. It makes for terrific copy. The bigger issue is hospitals have health plans at their mercy by buying up physician practices, by consolidating horizontally, and that's by far the bigger driver of spending and the bigger dysfunction beyond just the professionals in surprise billing situation.
Just before I want to get to your point, but you mentioned consolidation. Often consolidation is cited as where we see it with high prices, we have worse outcomes. Is consolidation the primary driver of this, or are there other things going on?
I'd say I'd put the fact that health insurers are in a position of bilateral negotiations with hospitals, and hospitals inherently have the upper hand by having features of natural monopolies. That tends to reward hospitals for further consolidation. The lack of any limit on out-of-network payments rewards consolidation, has fueled consolidation. It's too late to try to unscramble that problem. This might take.
First, I think Schaeffer is spot on. I'll say a little bit more about what I would add to that. But again, in the spirit of what I said before, because some people see healthcare spending as a tapeworm on our economy, that's a Warren Buffett quote, and others see it as a Keynesian stimulus. Those two views are hard to reconcile. It's important to, I think, be more timid than you otherwise would want to be. So while I agree that you want to set some cap on prices in a range of ways, I think we're going to find that cap will be Medicare plus X, and the X might be pretty big. I have no problem with that. So I think you're going to have to add to the first, in the spirit of what Schaeffer was saying, the first point is start with getting rid of the most egregious problems. It turns out we have a lot of egregious problems. So start there, that's timider, it's easier to justify, and then begin to build some things, for example, like they've done on Rhode Island, where you limit the rate of growth of prices, so the cap will get the worst cases, then you want to deal with some prices underneath where the cap is. I think you want to make sure that when you design this, you give a role for competition. Should competition begin to work better, let it work better. But I don't think we have the luxury of waiting for us to sort through transparency and unraveling mergers and doing a bunch of other things. We should just find the most egregious cases, as Jacob, I think, was talking about, figure out a policy response to them, and hope we can do better at the basketball.
Are there other potent antidotes goes to consolidation. I think about, mandatory value-based, broader value-based models. When you align incentives, right, did the negative outcomes that we're seeing associated with consolidation in terms of high price, lower outcomes, is value-based care an answer to that?
So I think we have to be really careful when we talk about value-based care and what we mean and where it applies. So, on the one hand, I think there's a reasonable argument that value-based care has had some positive effects at the margin in the Medicare program. And so my issue is that hospitals and other providers talk about value-based care all day long, but what we're actually seeing on the ground in terms of their price increases and rate increases from year to year is that all the value-based care in the world isn't going to save us, because any savings from, reduced readmissions or lower ER rates are being completely swept away by higher prices on the care that remains and will always be provided.
I just wanted to say, and maybe these guys will correct me, but the way I think about value-based care is that it can improve care, it can improve the infrastructure for providing care, but I think a lot of the value-based care models end up having benchmarks. Generally speaking, with value-based care, you've got a target you're trying to hit, and then there's shared savings and that sort of stuff. And so it's critically important how you set that benchmark. And where I would look for progress on this front is to steadily tighten that benchmark in a way that you're moving more towards what you think the cost of care actually should be. And that's easy to say and hard to figure out. But until we start putting some price pressure on, then underneath this value-based care structure, you haven't really changed the incentive among the providers.
And benchmarks work a lot better when you're dealing with somebody who's a price setter, like Medicare, than a price taker, than many private insurance companies.
Yeah. So, I just want to learn how to use my fingers. So, I think the word value-based care people like because you can say volume to value and both begins with a V, that's very appealing. It's actually not about, I care a lot about value. I'm a nice enough guy, I'm sorry, I really wrote a really slow guy. But this is really about shifting accountability for spending onto a different group of people. It's about shifting that accountability to providers. It turns out that in a system, and I'll use the word capitation, I don't like using it in public, but in any case, it's easier. If you set a really high target, you'll spend a lot of money. So Medicare works, I think we have saved, I think there's a lot we can do to refine the way those models work. I think in the commercial sector, you can see more of this with some challenges, but I think the key question is how we begin to think of placing limits and what role benchmarks can play in placing those limits versus a role in which we try and just lower and lower and lower prices. The reason why Medicare has been so successful on a per capita basis is it turns out they've set very low prices. And in fact, projected to go forward, they've set prices for physicians are getting no nominal raises basically for the next 80 years or something. So we've really done that in Medicare, and I think we have to think through how to deal with that.
Let's talk about prices for a second.
Can I say something about value-based care? So in Medicare, we have these two-sided ACOs, one-sided ACOs, value-based payment modifiers, and Medicare is on the cutting edge. Meanwhile, in private health insurance plans or employer-sponsored insurance plans, you still see a lot of plans paying discounted charges. The provider submits a bill and the insurer pays 75% of billed charges. That is an egregious antithesis of value-based care. It's worse than fee-for-service. Fee-for-service is a provider provides a service, the insurer pays a negotiated rate. That's the core of Medicare's payment system. Discounted charges is an abomination. It is not working for the privately insured, and it's hidden behind a veil of secrecy in the negotiations between private insurers and providers. And in the value-based payment area, I think we need to focus a lot more on bringing up the rear, getting rid of discounted charges, and worry less about figuring out a two-sided risk-sharing model for rural ophthalmologists in Medicare. Medicare has basically they've got the basics right. They've got a solid fee-for-service infrastructure in the private insurance markets. That solid fee-for-service infrastructure is missing, and you have hospitals wanting to leap to accepting capitation because that bakes in the excessively high prices that they're getting today.
I want to go back to the hospital spending and a point that you made in terms of what is the sort of appropriate cost and who's responsible for that spending. We recently did some analysis in California looking at the OSHPA data comparing the Medicare payment to what the private payment cost of payment data for hospitals, and the average was 200%. But there were some health systems, Stanford, Sharp Memorial in San Diego, approaching 300%. Schaeffer, I know you did some work in this space, and one, I want to figure out what did you find in terms of these asymmetries of cost of payment that exist, and then I want to talk about cost shifting. And if we have enough data to officially debunk what I believe is a myth, but I'm curious on the rest of the panelists. So perhaps what have you found when you look at these asymmetries of cost of payment, looking at Medicare versus the private sector?
Yeah, the most dysfunctional pricing that I see going on is privately insured employer-sponsored plans paying for hospital outpatient services. Hospital outpatient services, there should be some competition from freestanding facilities, from ambulatory surgery centers and so on. Prices for hospital outpatient services should be more in line with their costs. That's not what we see, and hospital outpatient services are where we see a lot of discounted charge contracting, and one of the contributors to that is that Medicare's fee-for-service payment system for hospital outpatient services is a hot mess. Is incredibly difficult to wrap your head around, and it's very difficult to benchmark what a private plan is paying to what Medicare is paying. It's so much easier for hospital inpatient, and it's really easy for physicians. And lo and behold, those price patterns are less erratic than what we see for hospital outpatient.
I think beyond even comparisons to Medicare, if you look at what's going on among people with commercial insurance, people get insurance through their employer. I mean, in San Francisco, the price of a C-section can be as low as $10,000 and as high as $40,000. This is a working-aged population for a relatively standard medical procedure, and yet we're seeing fourfold variations. So you could be in a room sitting next to somebody, and your employer could be paying 4 times what their employer is.
Let me ask about that. And is that because some health systems, have just figured out how to operate more efficiently, and others have intrinsically higher costs that are justified? Or is that we've seen some health systems that are operating more efficiently and therefore can operate at a lower cost of payment ratio, and others are just either operating sloppily or predatory behavior?
I'm talking about the same hospital is charging $10,000 to one patient and $40,000 to another patient, and they both have private insurance.
I think part of the mistake is it's important not to start with the premise that there's a certain amount of cost that we have to pay for it, right? And so that's not the case. And you will often find reimbursements cover costs. That's not because you have got reimbursed enough to cover your costs. That's because your cost rose to meet your reimbursements. And you really have to think through that. I think the caution, which is the question you asked, is it is very clear in a strict, narrow economic evaluation that there's not a lot of cost shifting. If a payer raises its rates, you don't see the prices. If Medicare raises its prices, you're not going to see commercial prices drop, for example. That said, what I think there's less evidence on is the broader dynamic that's going on. And what I worry about, though, I can't prove, is the following dynamic. Medicare, through all of its successes, held prices down. That has put a lot of pressure on facilities in some ways. The response, we can debate, may or may not have been to control spending, but a lot of the response has been to consolidate and make up the differences on the commercial side. That's not a classic cost-shifting argument. That requires some organizational change underneath. I think we have to think through the inefficiencies that work in a world in which you have one segment paying half as much as the other segment, and just the economics is, if you have one segment paying half of the other segment wants the lower price. And then you end up with a bunch of policies that are basically lower prices for all. It has a different name. But anyway, is where I think we have to understand that even without a narrow version of cost shifting, we have something going on, and we really have to figure out how to address that, because we have to not worry about the cost shift. We have to actually just worry about the cost. The costs have to grow at a slower rate.
Before we move on from prices and talk about some of the opportunities in Medicare and Loren, I want to ask you a question. We hit on prescription drugs before, and you've written about insulin and other drugs in this space. We can focus on the prices, but there's also this trend moving towards more expensive products, right? And in insulin, a lot of it has to do with delivery. How do we have to think about one, controlling pricing, but also just controlling sort of utilization and appropriate, limiting to appropriate switching to perhaps later generation and more expensive interventions?
Well, prescription drugs are tricky because there's a lot of new product entry, and those new product entries tend to be, in many cases, Hep C, as an example, truly life-changing and life-saving drugs. So there is a separate conversation about what are appropriate launch prices for these new drugs that have had a lot of R&D. But if you look, and I know that insulin came up on the previous panel, but if you don't have to just look at high-price new entrants. You can pick just about any drug and track pricing increases over time, and they have been very substantial. And then the industry chooses to hide behind this facade of, well, that doesn't include the rebates, but we're not going to give you the rebate information. We're going to criticize you for not including the information we won't give you in your analysis. Not sensitive at all. And also, I think too, there's a really important point here about list prices. People should realize patients pay list prices every day in America. Uninsured patients pay list prices, and deductibles, frankly, have gotten so high for many people with insurance that if you were in the deductible portion of your benefit package, you are paying list prices for insulin and all those other drugs, and you are being directly exposed to those what I would describe as unconscionable price increases over the past few years.
So, I think some of your question was about volume and high versus low value volume of utilization, and I think that's clearly true. And I think part of the problem is that there's a lot of incentives buried in the system that we've had a hard time getting rid of that encourage the use of low volume services or higher price services. People getting paid, for example, a percentage of the price encourages people to use a higher price up the lower price, for example. I think in the drug case, the biggest problem with rebates, apart from the fact that we don't see them, and actually I think they're really large in insulin, I'm not sure this was the best example, but that part aside, is that because people are paying out of pocket related to list, you get some really, really egregious problems. Right? So there's just two separate problems. One is we're worried about the cost problem because the out-of-pocket prices are high. We're worried about the cost problem because the overall spend is bad. Those are different problems that we can solve in different ways. But there's a lot of low-value care in certain places, a lot of care variation, and I think to the credit to the medical profession, through things like choosing wisely, and increasingly there will be attention to getting rid of low-value care and promoting high-value care, which incidentally would largely be insulin.
So let's stick there and switch over, to we've been covering a lot of space here, but strictly, within the Medicare population. Mike, you pointed out that overall we need to grow into a more sustainable base. Certainly, nowhere is that more true than Medicare, because we're not going to change the demographics, right, in terms of the number of beneficiaries. But what are are there opportunities and policies around low-value care within Medicare that could be impactful?
I'm a proponent in Medicare of continuing the path that Schaeffer started talking about, which is the value-based type path. I think one thing you want to have in the system is a system where an organization can be more efficient. They get to share in some of the efficiencies, which is typically not what we have. The Medicare fee schedule has a ton of issues, so I think there's a lot of stuff to do with drugs. The last panel discussed. I'm scared to talk about it anyway, so I won't. There's stuff on secondary payments also came up in Medicare. There are real examples of Medicare where you can do a better job, but I do think fundamentally in Medicare, we have increasingly a demographics problem. We have held Medicare per beneficiary spending growth to a reasonable rate, and there's other things on our Medicare baseline, the projected increase in fees, for example, that I believe are probably lower than we're actually going to see. I don't believe we will see physicians getting paid what is currently projected for them to get paid 20 or 30 years out. And the only way we're going to make Medicare work, back to the theme that you raised, Tim, is we need a way to allow organizations to convert excess low-value use into revenue for them so they can survive on a total revenue amount that is lower than would be projected if you gave them just their fee-for-service utilization and paid directly more realistic prices. And I do think in Medicare, those mechanisms exist. It's just a question of doing a bunch of small, wonky things, getting benchmarks right, dealing with rebasing issues is really fun.
So the mechanisms, I have young kids that like to number ball, right? So I think some of these mechanisms and policies is the numbers which in, the ball goes down or someone optimizes, their efficiency, within the system. Can it be, and how may I ask you this? Is optional okay, or do some of the, do some of these mechanisms or, structures need to be mandatory for that to have a meaningful impact?
I think that you're not going to get to mandatory. I think optional is actually fine as long as you hold the line on prices to encourage people to get it and design them better. I think there's a lot of participation. We've been trying to push people so hard to things like downside risk and stuff that I think we worry about participation. I think I'd be happy if we got to the right place in 2025. And if there's another solution, like have more kids, just whatever you're going to do later, have more kids, that will help us. But other than that, you have to think about how to build something successful for 2030, and I think it's there, and I think you can do it with a reasonable trajectory of benchmark growth. And I do think you can do that voluntarily.
So, I don't know how much I disagree with Mike on that, but I feel like, yes, we should continue the value-based stuff, and I think we should keep an eye on MA, which is working pretty well, but also maybe somewhat overpaid and put pressure on them as well. But I think that it's not so much that you want to make the ACOs, et cetera, mandatory as that you want to make some changes in the underlying program mandatory. Like if we find a way to really go after the value care, if we can deal with these wonky overpayment issues, then you have lowered the base that the value-based entities are aiming at. And so I think it's a mix of, yes, I respect Mike's judgment that we want to let value-based entities form themselves, right? And so let that be voluntary. But still, what we want to do is keep pressuring the program, get at excess spending wherever you can, just by making program-wide changes, and then that will partially fix the benchmarks.
I just want to thank Holly for pointing out that in our ongoing love affair with Medicare Advantage, they have been historically overpaid and probably still are.
I just say one word, coding.
So, when we open this, I would find that perhaps there's some opportunity for us to think about how, sort of public policy reform might be able to support the private sector. Are there some things that we can do within the Medicare design that would either support or allow for exportation of certain sort of principles or mechanisms that could accelerate move towards value or the overall cost curve on the private sector? Kevin, or not?
Yeah, site-neutral payments. Every year MedPAC, reiterates site-neutral payments would save Medicare program money. It makes sense. In my mind, it fits in the bucket of value-based care. The idea is not to pay extra based on a service being delivered in a hospital outpatient department instead of a physician office. If Medicare moves further in the direction of site-neutral payments, that will have spillover benefits for the private health insurer. So I'll just pause there. And it would help with private insurers getting a handle on what they're paying to hospital outpatient departments. It would also ease off the rewards to consolidation, and it would dampen the rewards to hospitals buying out impacting spending trends for the private insured.
I think, Schaeffer's point highlights the difficulty of all this, because if we can't get site control payments done, and if we can't, get surprise billing done, even though there's a lot of, great efforts and activity on it this year, and maybe we will get some to the end of the year, how are we actually supposed to deal with the bigger, harder issues like, setting a cap, a proportional cap above Medicare prices that commercial prices couldn't achieve? It seems like a huge lift to me right now.
Medicare, clearly there's some places we're spending too much, right? Perhaps the price is fine, but just there's too much, lower value care, right? But we also know that 80% of your health outcomes, right, roughly, right, are not related to medical interventions, right? The broader, social determinants or other factors. How should we think about rebalancing perhaps how those dollars are deployed? Is that benchmarks? Is that policy, or is that shifting the responsibility further downstream to providers with greater flexibility to achieve that?
Well, the reality is we've systematically gone into social safety net over the last 20, 25 years. And so addressing social determinants of health is very important. I can't underestimate its importance. It is, I do still think it falls into that category of things we'd rather talk about as opposed to having difficult conversations about cost containment. And for me, nothing highlights the absurdity of the American healthcare system, where we'd rather overpay hospitals and plans so that they can turn around and launch, minor homelessness initiatives or food security initiatives, and they get, praised for it, but we've systematically underfunded those programs for generations.
A lot about Medicaid, which is fine. I think the intersection here is where you have the duals, so there's a lot of Medicare and Medicaid dual beneficiaries. And I think one advantage of a Medicare Advantage model or a Medicaid managed care model is you can move to a closer population-based type payment, and you can allow organization flexibility to decide what to do underneath that. You still have a whole slew of very complicated interactions about funding streams that we have a challenge with. How does it deal with the criminal justice system, for example, interacting with things? And we haven't done a lot of research on the financial implications of various types of interventions to deal with social determinants of health. So I think there's a lot of evidence that you can have a lot of success with a range of public health programs, smoking cessation, there's a bunch of others that I can point to. It's not clear those alone will solve the core fiscal problems we have. So while I think we have to do that and create a mechanism with which you can do that, I think we have to be careful of sort of feel-good interventions on the belief that the end that will solve our bigger problems. But I think we need to start with addressing the most egregious market failures we see. And in addition, see what we can do in other ways.
Great, no doubt. And I don't underestimate the potential reform within the Medicaid state and within the states. In fact, if you look back to 2000, there were 14 states that spent more on healthcare than they did on secondary education. And today that's 44, right? So there's clearly things that need to be done there. I want to go to a point that you mentioned, population-based, and maybe Holly, I'll go to you on this. As we think about shifting the cost of care, right? I think that's the language used, downstream, some, putting that responsibility closer to the individual. How should we think about sort of that cost of care on an episode basis versus a population basis?
Well, I do think if we knew how to figure out the right way to pay on a population basis, that probably is a level at which it gives you the most flexibility underneath that for innovation in correcting the incentives. But I think what is proven difficult is figuring out how do you pay on a population-based basis, make sure that every population gets to be in the plan, and make sure that the risk is accounted for appropriately, so there's not stinting on care, which is always a worry. And so I do think part of what we should be doing in our project is looking for where is the right locus to try try to fix the market failure or the care failure that we see, always aiming towards making healthcare more affordable. And I do think aiming towards population-based payment is a good plan.
The evidence on episodes are very positive if you look at joints, so there's like a gazillion studies on rates. Anyway, there's a lot of studies on like CJR, which is the joint episode, or joint part of payment for care improvement. There's a lot of stuff that can work, and a lot of that stuff all works for ACOs as well, because they pull money out of post-acute care, which is a separate question. But if you look broadly across the landscape of episodes, there's a lot that don't do very well, and it's very hard to figure out how to get these episodes to play together. And I worry that if we just decide episodes are the right way to go, and we're going to move into joints, that's going to be challenging. Even areas that I thought were going to be easy, cancers, because oncology care model, have been harder to make work on an episode basis. I think Alvin's right. The risk adjustment portion of population payment is the big Achilles heel we have to get at. But if we can get over that, I think that is probably the best foundation to build. And then underneath it, or on top of it, whatever, you could have an episode-based payment model for conditions that lend themselves to episode-based payment. And you always have to figure out who's going to be the loser of these in many of the answers of post-acute systems.
Let's switch gears a little bit and talk about employers. As part of the work we do, we focus a fair amount on strategies that employers can utilize to control costs. And some of the outcomes of interactions with C-level executives are kind of interesting. In fact, the other day I was talking to a CEO of a major multinational company and asked him what strategies they employing to get control over their employee health expenses. And the answer was, none. We pay them because it's table stakes. It's a competitive, sort of landscape, and we just have to, we just have to cover it. And I guess I'll start, to the group. Is that going to be a winning strategy for employers moving forward? And if not to be leading this, where are some of the bright spots that are out there in terms of what can and are being done to start to exert leverage?
Okay, that's a great softball. Okay, let's see. GM, General Motors, they are a colossal employer. They're extremely sophisticated. They're very aggressive. They set up a direct contracting arrangement in Detroit with a major hospital system there. They're throwing their weight around and to good effect. And there is just a handful of employers like that. Most employers, even the big ones, even most of the jumbo ones, are tuned out and just hoping somebody else will come along and fix the problem. And they're paying premiums that are growing 5+% a year, and they just accept that as the cost of doing business. They wish it were different, but there's a major failure to coordinate among employers. Let me throw one new idea. So we're supposed to be talking about that.
Before you throw the new idea, one question you have, they accept it as a cost of doing business. Are they purely absorbing that, or is the cost of that reflected in the wage growth?
It's coming out of wages, and they're all competing for the same workers. They're all dealing with the same insurers, and even though from a macro perspective, premium trends for the privately insured are totally unsustainable. No one employer can step in and fix it. They're competing. They're competing for their insurers need to pay physicians, and there's a national market for physicians and so on. So I do want to talk about the national ABCD in a sec, but okay. So there's a failure of coordination among employers. There are isolated bright spots, but the context for this is on the Medicare side. It's an incredibly data and analytic-rich environment. We are all over what is happening with spending, risk adjustment, prices, everything in Medicare we know what's going on. On the commercial side, thank goodness we have the Healthcare Cost Institute to give us some glimmers of information. We have state all-payer claims databases. Thank goodness for those. They've got a glaring hole because of the Supreme Court Gobet decision. They can't compel ERISA plans to contribute claims data. We're more or less flying blind on the private health insurance side of things. And a national all-payer claims database is an obvious step forward. It's not going to fix the ills of consolidation, but it's going to open up the book so that we can at least see the pieces on the table.
And will that on its own, if you think about anti-tiering and anti-steering gag clauses, either the contracting, provisions that are utilized, to achieve high price barrier control. Do the ABCDs, get us 80% there, 90% there, or what other policies are going to need to be, sort of layered on top of that to really empower the employer?
Okay. So, well, I'd love if people just talked about national ABCDs all day, but you bring up a really good point, Tim, about the gag clauses. You talk about employers. Look, labor markets are tight, as very few employers want to be the ones that take an aggressive approach to benefit design for their employees because they're afraid they'll lose them. Even those employers that want to do it. There was a Wall Street Journal article about a year ago where a major employer approached their TPA and said, we've run the numbers, we want our network to include everybody except this facility. And the TPA came back to them and said, I'm sorry, our arrangement with that facility means that we have to include that facility in every single product that we offer. So most employers aren't engaged, and it is a cost of doing business, and even the ones who are trying to get engaged find themselves blocked and tackled by the intricacies of the system. Now, to ABCDs, will they solve everything? No. But what it will do is, I think, is contribute to a sense of systemic health system transparency, not consumer-focused transparency, systemic transparency, where the crazy distortions that I highlighted earlier, where the same hospital can have a 4 or 5 or 6-fold difference in what they're charging for the same service to the same working population, that can be exposed, and maybe then employers, because if I'm an employer paying 5 times what another employer is paying to a different TPA, I'm going to be outraged and I'm going to demand to know what is happening.
And the other thing is, the employers respond to the fiscal pressure often by making their benefits packages less generous, and that's where you see a lot of the political pushback. So while it's very hard for them to figure out what to do in terms of their network, in order to address the problem, they push more onto the patients, and they do that. It breaks the spreading that's inherent in insurance in the system. So we struggle with an increasing divergence of the out-of-pocket payments that people have, and a greater burden on people with more serious and more complex.
Literally a math problem they're trying to solve every year. What is the kind of equilibrium, premium raise, benefit reduction that they think won't cause, revolt/unhappiness among somebody?
Right. I mean, I have the honor, and by that I mean misfortune, of chairing the Harvard Benefits Committee that advises the provost. We lowered our generosity from 95% actuarial value, I know, to 91% actuarial value, which is still above platinum. I do town hall meetings. You never want to do town hall meetings. So the pushback you get from employees when you do this is the real challenge. We're not necessarily a typical employer, but that's where this tension is. I think what you're seeing across the country is people are outraged at what they have to pay out of pocket. The wage trade-off, which is exactly what you mentioned going on, is much less transparent to them, and so you get this dysfunction because the employers would like to be able to take on the delivery system, they can't, so they shift it to the workers. You get a lot of
Can we talk about secrecy, the veil of secrecy? So Uwe Reinhardt, thank goodness for his turns of phrase, described hospital contracting, hospital pricing for the privately insured as chaos behind a veil of secrecy. I up that a little. It's not a veil of secrecy. It's a moat and a brick wall that's growing higher. And a core feature of the concept of a national APCD is to say, listen, the current setup has insurers and hospitals and physicians negotiating in secret behind closed doors, and the rest of us pay the prices they reach that are entry is not working for the rest of society. And one of the concepts that has to be made in the national APCD is to say, listen, allowed amounts, the amount the insurer is paying to providers, that cannot be a proprietary trade secret. That it's the concept of giving a receipt to somebody who's bought healthcare services. Employers, they want to cut a hospital out of their network, and the insurer says we can't because of our contract. The employer, if they say, let me see the contract, I bet you the insurer will say, we can't show you the contract. You're paying prices based on this contract. you can't see it. That's not working for the rest of society.
Marc, I'm going to let you get it in, but I'm looking at the time here, and it's my job to land this plane on time. So what we're going to do is final takeaways, 3 sentences or less. We go down, and I'm going to give you a second to think about it, but just thanking the panel for joining me. But just as I reflect on this and I think about the high cost of healthcare, it's not a health sector crisis. It's an education crisis. We've talked about that. It's an infrastructure crisis. It's a security crisis. And I'm just really thrilled about the partnership moving forward to advance, new policy ideas, and not just ideas, but get them implemented, around cost containment, and really looking forward to engaging with many of the stakeholders in this room to shape it from the very beginning. So with that, as my final thought, perhaps Holly will start with you. Brevity is the soul of wit here, because we're out of time.
And I don't know which brief to be. So, some great ideas I heard today, or thoughts that came to me while we were talking. One is fixing some of the broken parts of Medicare, and I think I'd like to think about when we do that, are there ways to then encourage or allow the commercial sector to piggyback on at least some more rational payment systems. So that's a thought. Benchmarks are my favorite thing to talk about. So finding a way to set benchmarks or finding a way maybe to crowdsource what's the right amount to pay for care and set benchmarks based on that. And then I think an elephant in the room that we didn't talk about around the National All-Payer Claims Database is would the existence of something like that in combination with the strong change in the way the tax exclusion works for employer health insurance lead to a different outcome than simply reducing benefit packages to try to stay below the threshold.
There are market failures. Fix them sooner rather than later.
Meaningful change is going to require collective action and a little bit of collective pain, and the sooner we realize that, the better.
In the Medicare program, the cards are all on the table. We're in tinkering mode. The president's budget, MedPAC, they're all over it. In the private employer-sponsored health insurance market, we don't even know what's going on under the hood. We need to see what's going on under the hood, and then we can start talking about fixes.
Great. Please join me in thanking them.
Thank you so much to the panel. That was excellent. I will add that in addition to being very excited about this whole partnership and project that we're working on, I was listening to that also as an employer and thinking about through some of the things. And I will share with you all that we recently not only implemented healthy snacks, we decided we would do our budget boot camp, or fiscal fitness, where our whole organization was invited to do boot camp and work out together over the summer. And I would say, without exception, every one of us got injured. So I know that at least for me, I went to both a normal doctor and a specialist, contributing to growing healthcare costs. So not all ideas are good ideas. Thank you. I think the panel today have been excellent, and I hope that you will now join me in welcoming our final keynote speaker, Senator Hassan, who is here from New Hampshire, who has been really engaged in the entire healthcare reform space, sitting both on the Finance Committee and the Health Committee, so she really brings a wealth of knowledge. And she has focused on the big topic of today in many ways, surprise medical billing. And so thank you so much to you for joining us, but also thank you for the work that you have done, both coming up with solutions with Senator Cassidy. You two came up with a bipartisan bill that really led momentum on this issue and led to some of the work. And I think you also highlighted the issue in the State of the Union when one of your guests was somebody who had experienced surprise medical billing. So I invite you to come up and join us and share some of your ideas. Thank you so much.
Well, good morning, everybody, and it sounds like you've had quite a morning, so thank you for including me in it. It is a real pleasure to be here, and Maya, thank you for the introduction. I also want to thank the Committee for Responsible Federal Budget for convening this event, and to everyone here today for participating in this discussion on opportunities to lower healthcare costs. Access to affordable healthcare is critical to the freedom, dignity, and well-being of all of our citizens. It also contributes to a productive workforce and a thriving economy. But right now, Americans are being squeezed by rising healthcare costs that present a real danger to our health and economic security. Something I have been hearing about since my time in the state senate in New Hampshire, and then as governor, as a consistent theme from constituents and business people everywhere. As a member of the Senate Health, Education, Labor, and Pensions Committee and the Senate Committee on Finance, lowering healthcare costs is one of my top priorities. And I will tell you that I come at this a little bit with both the experience that I just shared with you, state legislator, then a governor, but also the mother of a 31-year-old young man with severe and significant disabilities and complex medical needs. So I have seen the American healthcare system from every which way, and I love the innovations and developments that have helped my son be with us and live at home with us. But there are real challenges, and obviously the costs are one of the biggest. The good news is that despite some of the partisan battles on healthcare over the past years, there is actually real common ground in certain areas to move our healthcare system forward. So today I'm going to discuss two of those priorities for lowering costs, ending the practice of surprise medical bills and lowering the cost of prescription drugs. As many of you know, and as Maya mentioned, one area where I've found eager Republican partners is ending the practice of surprise medical bills. This is an issue I've heard about from a number of my constituents who have truly harrowing stories about these unexpected and unfair bills. Donna Beckman, the woman I brought with me to the State of the Union address, has medical training herself, had symptoms on a Sunday morning of what might have been a heart attack, called her doctor's office, got the 24-hour nurse line. They said, yes, you definitely need to go to the emergency room, went to her in-network emergency room, got a full range of tests. The good news is she wasn't having a heart attack, she's fine. But she then later got a bill for about $1,600 because one of the doctors that had read her diagnostic test results wasn't in network. Contract doctor who would come in on a Sunday to take a look at it. And when she called the insurance company, they said, well, you chose an out-of-network provider. And this notion that when you're in the middle of a medical emergency, you have choice here is kind of overwhelming. And she said so. And the good news is it got resolved. But that is one of the cases and stories that really got me focused on this. And it quickly became clear that the incidents that I was hearing about in New Hampshire were not isolated ones. Sarah Kliff, who I think was part of your first panel, has done outstanding reporting documenting how widespread this practice has become and how it is impacting families all across the country. Another woman who told me about her story, a woman from Virginia, the surprise medical bill they got after their son took a baseball in the face during baseball practice was $35,000. And she said to me, that's college tuition for a year. I mean, the impact is huge. So over the course of the last year, my Republican colleague, Senator Bill Cassidy of Louisiana, and I, along with colleagues from both parties, have worked closely to develop and push legislation to stop surprise medical billing. In crafting our legislation, Senator Cassidy and I studied a variety of approaches to settle these disputes, and I've appreciated the constructive input we received from some stakeholders, including patients, hospitals, physician groups of different specialties, employer groups, and insurance companies. Our top priority has been taking patients out of the middle of these billing disputes between providers and plans. And I am pleased that appears to be an almost universal goal. I mean, the whole idea of buying health insurance is not to have a surprise bill, by definition. Health Committee Chairman Lamar Alexander and Ranking Member Patty Murray, as well as their counterparts in the House, are all committed to addressing this issue as well. And earlier this year, as you all know, I think the Health Committee passed surprise medical bills legislation, which was a critical step forward. But what has been just as important is that with the leadership and support of Chairman Alexander and Ranking Member Murray, we've continued working to improve the bill since we passed it out of committee. As discussions with the Health Committee continue, one of the things I'm focused on is incorporating additional flexibility to ensure that any new law will work for people in all areas of the country, because the challenges of patients and healthcare providers are different. In places like Pittsburgh, New Hampshire, population of about 900, than in Pittsburgh, Pennsylvania. We must make sure that this law protects access to healthcare for everyone. An independent dispute resolution approach, similar to what Senator Cassidy and I proposed, is a reasonable compromise that will work for providers, hospitals, and health plans. And importantly, I believe that this is the approach that can secure enough support to pass the Senate and become law. Our approach would give both sides incentives to resolve billing disputes in good faith. It would give rural providers an opportunity to contest payment rates if the benchmark payment is unworkable. And we are working to make sure it can be done in a way that does not allow bad actors to manipulate the system on the backs of patients. Throughout the process, we drew on the experiences of states that have already moved forward in this space. For instance, in New York, analysis has shown that using providers' billed charges as a basis for what to consider during dispute resolution led to increased costs. That's why our approach instead uses in-network rates, which will result in billions of dollars of savings, according to the Congressional Budget Office. There are still adjustments that need to be agreed to, but there is a real desire right now to get this done. I remain committed to continuing to work across the aisle in the Senate and with our colleagues in the House to get this done, and I'm really hopeful that we can get it across the finish line this year. Now on to prescription drug costs. That's another pressing healthcare challenge that I know has been a good part of the focus here today, and perhaps is the single issue I hear about more than any other from constituents. They really want us to address the skyrocketing costs of prescription drugs, because affording life-saving medications is getting harder and harder, and it is forcing seniors and families to make agonizing decisions. In one of my North Country, which is our most rural part of the state, community health centers, they have 3 full-time people who do nothing but help patients try to find ways to afford their drugs. I mean, this is a really small community health center. No one should have to decide between buying their prescriptions and heating their home or putting food on the table. But these are the type of choices Americans are devastatingly having to make, all while pharmaceutical companies are reporting record profits. So this summer, under the leadership of Chairman Grassley and Ranking Member Wyden, we advanced bipartisan legislation through the Senate Finance Committee to begin to take on big pharma and lower prescription drug costs. As Chairman Grassley and Ranking Member Wyden noted, this bill would cap out-of-pocket costs for seniors on Medicare Part D and crack down on pharmaceutical companies that raise drug prices at a rate higher than inflation. It would save Medicare beneficiaries more than $30 billion in premiums and out-of-pocket costs, and it would save taxpayers $100 billion in Medicare and Medicaid spending. It is truly a big deal that a bill taking on the pharmaceutical industry and lowering prescription drug prices in a meaningful way advanced out of committee with a strong bipartisan vote. And it received support from the AARP and the White House too. I was really encouraged by that major step, and we have to keep pushing to get legislation through the full Senate this year. And I'm really pleased that the chair and ranking member are working to continue to build that support by, I think, coming together with a package that can broaden participation in the Senate. I am really grateful to be here with all of you today. It is absolutely critical that as a lot of Americans are seeing a very partisan and divided country on TV, that here in the Capitol, with the help of so many of you, we are continuing to work across party lines to work on the things that our constituents tell us are their priorities. But I will also just say that the reason we have made progress on surprise medical bills, and the reason we are making progress on pharmaceutical costs, is because the people of our states, the people of this country, have demanded it as they should in a democracy. I want people to take heart and take note that when healthcare has been an issue in this country, people have traveled in droves from all over the country, overcoming significant barriers and obstacles to get here, to let us know how important healthcare is to them. And as an intellectual matter, that shouldn't be hard for any of us to understand. And certainly from a policy perspective and a budget perspective, it's a really important matter for all of us to grapple with. But at the end of the day, this is about people in the United States demanding to be heard and counted, and reminding their elected officials that this is about their dignity, their freedom, their economic futures. And in reminding us of that, reminding us of the importance of this issue and our solving it to this country. So I have the privilege of hearing from my constituents and hearing their suggestions on an ongoing basis. It is the best part of this job. It is our job here to follow the examples of the people we represent who solve problems every single day, whether it's in their businesses or in their families or in their communities. And I know that everybody in this room, because you're part of this group, shares that commitment to problem solving and shares that commitment to pushing all of us here forward to remember that at the end of the day, the American mission is to bring out the best in each other, and in doing so to solve problems and move forward, thrive, and lead. That's what this is all about. That's why it's so good to be with all of you today, and I look forward to your continued work and our continued discussion. Take care.